podcast. Hello and good afternoon. It's wonderful to see you here in November. It's hard to believe we're approaching the end of 2024, but we're so excited to continue with our culture and tradition of professional development, reaching you all around the world. Today's presentation is by Dr. Ann Henshaw, who is out of Washington, D.C. She is an expert in palliative rehabilitation, specifically advocating for the role of OT and immersing the role of OT in interprofessional teams. To share with you a little bit about what you can expect today, which is similar to other monthly sessions that we have here in OT Echo, is that we'll start off with a mini lecture by our speaker, Dr. Ann Henshaw. You can use the chat box to ask questions. She'd like to answer them throughout the presentation, but for any that are missed, we'll capture at the end. We'll also go into breakout rooms today after a case example is presented. And we do encourage you to have your videos on and participating in the best that you can for the ultimate inclusion and outcome and application of today's material on your own learning. We'll finish up today with Ann debriefing the case, taking any last minute questions. And as always, please stay tuned to your email where we'll be sending you a post session assessment from Dr. Kelsey Sullivan, as well as a certificate of today's presentation with the recording. All right, go ahead, Ann, take it away.
Thank you so much, Sarah. It is great to be here today to share my passion for palliative care and palliative rehabilitation and the role of occupational therapy in this space. So our goals for today are to define palliative care and hospice for individuals with serious illness, to define the role of occupational therapy in this space in the end of life as part of the end of life team, to describe the alignment really of palliative care and OT and the goals in palliative rehabilitation, and to identify 3 OT interventions. We'll talk about more, but at least 3 that allow meaningful participation at end of life. So before I get too busy, though, let me tell you a little bit about me and how I got here to this role. So I've been an occupational therapist for many years. You had an undergrad bachelor's in it, and then got my master's in public health and an MBA. And then finally met Dr. McKinnon at MGH, where I got my doctorate. I'm from Boston, and I now live in the DC area. My OT lens has been informed by the people of my life that have passed away. And so specifically what triggered my interest in OT's role in end of life was the loss of my brother there in the middle of the screen at age 46. And other people, my parents and 2 uncles and a small child, Maddie Brown, who was the friend of my daughter's. And all of these people, as they underwent their occupation of dying, and that's a term you'll hear me say, sort of they're living while they're dying. All of these individuals benefited from my lens, from the occupational therapy lens, but very few of them were offered that lens. And so that really triggered me to go to where we are today and what we're discussing today. So that's my background, and everybody's obviously is unique. So what I'd like to know now that you know something about me is a little bit about you, and maybe if you could just put in the chat on a scale of 1, which is no way, to 10, definitely. I want to know that first question. Do you feel adequately trained to treat individuals at end of life or with serious illness? Anybody want to let me know what numbers are coming into the chat there about, do you feel like, yes, I definitely feel like I can do that, or maybe not. Maybe I don't have that skill set. I can take a look myself. We see some nopes. A 1. Okay, so mostly low numbers. Yeah, I really think that's a barrier that has been identified, is that we're not necessarily trained for dealing in this end of life space. However, many of the things that we'll talk about today are very core to the occupational therapy process. And now, how about the second question? Do you wish you were? Do you wish you could do more of this? Is this a space that's interesting? Maybe throw some numbers in there. You wish you had some? I know we don't. We got a nose. We got now some 7s, 3s. Okay. All right. Well, I'd just like you to reflect so that you can sort of understand the skills that we have to bring to bear thanks, Claudia. Claudia says 9. I like it. She wants to work with me. All right. So I just want us to reflect a little bit on, what we think we're trained for versus, how we can go about maybe sort of beefing up that muscle so that we can be more present in these spaces. Because I assure you that we are very much needed. So a little bit of background, and I apologize if this is sort of US centric a little bit. So I might be, if I'm not speaking to your space, I apologize. But overall, the term palliative care or the palliative care continuum is really a medical term. It's a subspecialty of medicine, not of surgery, but of medicine. And their focus is on all these things that are there: managing symptoms, looking at addressing quality of life, this person and family-centered care, and holistic care. And I would challenge any of you to say that what else that represents, right? I think it's occupational therapy. When I look at any of the things in the palliative care or the palliative rehabilitation space, much of the goal concordant care or the goals that they're working with patients on are very much in line with what work that we do as occupational therapists. Okay, so that's my one message for today that I hope I get across, that we are very well aligned. The OT process and the palliative care process, we're all trying to self-actualize not just what we think is important for clients, but what they're telling us they want to do or is important for them. So a little bit of what palliative care versus hospice is. Palliative care can occur at any stage of the illness. It can be concurrent um, with treatment care like chemotherapy or antibiotics or things like that. It usually occurs in the hospital, although there's different outpatient models that are popping up all over the place now. And it's typically paid for by insurance, at least from in the US. Now, hospice is different. You have to have a diagnosis of 6 months or less to be included in hospice. Excludes curative care. So it's usually at a point in your journey where you're saying no more chemo, no more radiation, probably no more antibiotics, no more active things to treating my symptoms, yes, but not the disease process. It usually occurs in a home setting and usually paid for as a per diem. So those things are sort of separate buckets, but really most of what we do is in the middle, right? We're all providing comfort care, whether it's under a palliative or a hospice umbrella, relieving symptoms that we'll talk about here in a few minutes, tons of psychosocial support, which I would argue we are well trained to provide, managing the complex issues of serious illness. And really the things that in my nirvana and the way that I would love the world to be is that we are providing life affirming interventions, really helping people with things that we'll talk about later, like legacy building. So we are well aligned. I guess that's my point of all this, of all the beginning background slides, is that we as occupational therapists are facilitating participation, increasing participation. Performance may indeed be declining, right? If a patient has ALS or a diagnosis that's a heavy burden, they might not go from moderate assistance to minimal assistance in a transfer or in lower body dressing or something that we have stated, but they might be participating more in things that matter. And I would urge you all to think through documentation to the degree you have to document around participation goals. Participating in leisure activities with a grandchild might be really an important task for somebody that's nearing end of life. And so we also address caregiver burden in the occupational therapy framework and definitely in the palliative care framework. But I really want you to focus on this participation, increasing participation in things that really matter to your client. Sadly, we oftentimes, however, work in parallel, the rehab team and the palliative care team. And my goal in the next 10 years, I've been a therapist for 38, so I've got maybe 10 more in me, is really to try to break down that bar that's in the middle, and to really overlap these two teams so that we have the same goals, and how can we work together better? And that's, really what my research has been on. I will tell you that the World Health Organization agrees with me for what that's worth, right? They have basically in 2023 came out with a policy brief that said rehab should be included in palliative care and hospice care. They have said that it's a right, that palliative rehabilitation is a right. Now, operationalizing that is, at least in my hospital, maybe you guys have a better story, but at least in, the spaces that I'm in, is really challenging, mostly from a resource perspective, both resources of people and dollars. But it is nice to know that the World Health Organization, and this is important information for you to provide to your, if you have an institution that you're at, let them know that this is the vision of the World Health Organization, that palliative rehabilitation and occupational therapy and palliative care should be provided concurrently. It's not a binary decision. It's not we're going rehab or we're going palliative. We can go together. Okay, palliative and rehab can be overlaid on one another. And this new model, I just wanted to share with you, this is sort of the new model that's being promoted in the more palliative and hospice space, and that we all know this already. I think that, right, life's a journey and it's not a straight journey, right? We might get a little bit, we might lose, get a little bit. I'm going to plug in I'm just getting sorry guys, I did not plug in my computer. And so I do not want to have okay, maybe I'll do that while I'm talking. Sorry about this. So that along the journey, that there's some sort of diagnosis, and the earlier we check in with a patient along this journey, the better. And so that we make sure that we are, even regardless of when this hospice actually takes place, if it does, because hospice and palliative care services might not take place, but when it does, that we are more and more involved in the process along this journey. So just wanted to share with you, because that's sort of a new continuum model developed by the Center to Advance Palliative Care, I believe. Okay, so what does OT do in this space? And we're going to go through this relatively quickly, and I will hopefully not bore you with details of what you already know, because it's a lot of what occupational therapy does in lots of other spaces. Okay, this isn't magic. It's just got a little bit of a different tinge to it, I would say. So I'm going to go through these 8 things, and if you have any questions, please feel free just to jump in. So number 1, ADLs. I mean, it's our bread and butter, right? But in the setting of end of life, or in the setting of serious illness, ADLs take on a whole new meaning, okay? Because it doesn't really matter what we or the family or the doctors think they should be doing for themselves. It's what matters to them to do for themselves, right? So, and eating is oftentimes a big part of that. People often want a toilet and self-feed. Those are 2 really important things that have been articulated. So working with speech and talking about comfort feeding, or making sure people can participate in not just the act of feeding, but the act of being together in a meal, right? Because that's really what OT is looking at. It's the routine of it, right? It's the routine of eating breakfast, lunch, and dinner, who's with you, and what conversation you're having. So that's ADLs. There was just a great article, if anyone's interested, that just came out on sexuality and end of life. Intimacy is a big part of our lives, and as we're dying, we need that intimacy, whatever that looks like for you, even more. I'm happy to share any of the resources with you. So really asking your patients what a good day looks like, and you can't make it go away, their disease process, but you can try to help them on a given day enjoy some activity. For my dad, that might have been watching a Red Sox game. So that's baseball. The second thing is functional mobility. Now, obviously, we work with PT, and this is, again, bread and butter staple of what we do, right? Remember, though, in the setting of serious illness, we are looking toward the future where people might need more support, right? So thinking forward around when we're doing equipment, or when we're doing mobility or home setup or fall risk management, that we're thinking forward, okay? And that's fall reduction strategies, I will say, in the end of life space, to some degree, and this is obviously a personality in getting to know your patient and family, or people that they care about, you almost can be a little bit more risk taking, correct? Because if the person really wants to do something in this setting, maybe it's okay to take a little bit of risk, all right? And sometimes OTs are the ones that are willing to have that discussion a little bit more with the patient. I had a patient who really wanted to go to the beach, and the doctors were like, "Oh, she's not well enough." And she was 98, and she really went to the beach every year with her with her grandkids, and she was on hospice. So they did have resources. So I helped the family really plan, medication management, transport, all those things, the logistics of going, and got her a trip to the beach. She died that December, but in August she was at the beach, and that was the family's memory. So being a little bit more bold around those things in end of life settings can almost be freeing. Fatigue management. This is something that, really comes to bear in the cancer space. A hospice was designed for cancer, for patients with cancer. And, now the number one diagnosis, at least in the US, is dementia or neurological cognitive loss. So we were set up to deal with cancer and the fatigue of cancer, but not really the how one passes away with dementia is much different than the logistics of cancer. But fatigue management can be across settings, across diagnoses. And again, helping people. I had a home patient who went home from the hospital to live with her daughter and granddaughter, who really wanted to get to know her granddaughter in the setting of cancer that was going to eventually take her life. And she really wanted to play with her granddaughter. But as I got to talk to her, she said, by the time my granddaughter gets home, I'm too exhausted. I'm too exhausted to play a game. So as OTs, right, we look at routines, right? We look at, what do you do during the day? Where do you want to spend that energy? Maybe taking a shower at night makes more sense than in the morning. Maybe taking pain medications before your granddaughter gets home. All those nitty-gritty details that we as OTs really, get into with our patients so that they can self-actualize. So this patient then would take a nap from 12 to 3, wake up and be ready to play Candyland or to play a game with her granddaughter. Okay, so it's really, nobody else is talking about that. We are, right? We really want to know routines and that kind of thing. Number 4, pain management. And this is one that I really want you to understand, because I would say most of the palliative care and hospice doctors or providers that I interact with do not see a role for occupational therapy in pain management at all. This is the surprise one. When I say, oh, we can do breathing, we can do mindfulness, and I gave you an app there that I really like that's free. That, because some of the Calm apps cost money, this one is free. Great 2 to 3 minute or 10-minute mindfulness exercises for your clients. And even clients that don't seem to want it, I could tell story after story about people who really do use these things later, when they're, especially right before a pain medication. Obviously, occupational therapy interventions are not taking pain med needs away. No, not at all. But in conjunction with pharmacologic pain management, the non-pharmacologic pain management that we can provide is a huge benefit at end of life, okay, as well as the psychosocial support of it, because we're recognizing sometimes these concerns. Number 5, cognition, visual perception. As I was mentioning, dementia is a big end of life diagnosis now. And in my mind, we're experts here, right, in setting up safe spaces, but also in the sensory approach, right? So making sure patients have their glasses on and they're cleaned, making sure patients have their hearing aids or a pocket talker. I put the picture of the pocket talker over there because in my mind, they're cheap, they're easy, and they're really helpful in the space of dementia and or any hearing loss, but especially with patients with dementia that you're trying to engage in activity and having a hard time because they're not hearing you. We might not be able to change the underlying, but we can at least address the sensory issues around the dementia, and working with family members around safety and compensatory strategies. All right, number 6. I won't spend too much time on this because again, it's our bread and butter of the equipment assessment. But I will say, in preparation for decline, make sure, if possible, you're asking for equipment that will facilitate their status now, but also later as the person declines. Specifically, drop arm commodes, toilet seats, or drop arm wheelchairs, or wheelchairs where the arm comes up or down. And the same thing for other things like shower chairs or wheelchairs to be more reclining, if that's a possibility. So here's the next 2 are really where I want to focus, and that is in the self-advocacy, social connection, and legacy building. And to me, this is the beauty of occupational therapy, is really helping people in this space resolve unfinished business, because they are indeed alive, right? And their family is engaged with them, and helping them find peace in this. There's a member of our community of practice through AOTA. We have a palliative care community of practice, and she works in a nursing home, and she writes obituaries regularly with clients. That's just a part of her OT process. And obviously, if clients have family, you don't need that. But if you don't, that's a very welcome OT intervention. Any sort of spiritual connections, phone calls. I had a patient who was at Georgetown who was supposed to go home and then really took a turn for the worse. And that morning we spent making phone calls to his nieces and nephews. He didn't have children, but he was not a guy with a lot of emotions, but he really wanted to share that morning what he his love and information to his nieces and nephews. And he died that day at 2 p.m. So we have to recognize when our goals can really align with really important parts of a patient's life. Um, and here's where there's been lots more written on this. But legacy building is a huge part of OT. Asking your patients, how do you want your message to be shared? This is obviously, there's a whole bunch of language around this space, like what do you understand about your diagnosis, and what have the doctors told you, and what's your understanding, and all those kind of things we have to clarify. But once we're on the same page, understanding how they want to be remembered, by who and how, can be hugely gratifying for both you and your client. Making cookbooks, memory collages, life reviews, any sort of getting affairs in order. Any of that work really does, help people from a mental health perspective. And it's hard work, trust me. I oftentimes have people ask, how do you do that? And it's not easy, but it's not something you do all the time. But you may be the only person offering that. Or even just saying, this is hard. What do you understand about this? What's going on here? So that you can engage in a conversation and align your goals with the client's goals, so that we're all working off the same sheet of music, and also sharing those goals with the whole interdisciplinary team. Those two slides I showed you before, where these two teams are working with the patient in the middle, let's really make sure that patient is in the middle, right? And guiding. It's called goal concurrent care in palliative care. Outings are big, like that beach outing I talked about. So you're trying to get those things done to the degree possible, especially in the hospice setting. So that was a lot. I rattled. And were there any questions there? Or are we good to go with the case
Yeah, we
study?
actually do have a question here,
Okay.
Anne, and it'll be referring back to some of the interventions in the role
Yep.
related to sleep. So,
Hmm.
what could OTs do to help with sleep for those struggling with sleep for, again, a variety of reasons, whether that's meds, diagnosis, pain, worry, etc.
It's a great question, right? And the role of OT and sleep hygiene in general, not just for end of life population, but in general, I think is expanding, which is, I think, awesome because it's an ADL, right? So for sleep, interventions around, scheduling things like pain medication schedules. The mindfulness things are really great for sleep. That UCLA mindful that I shared on there is a great sleep. Plus, there's lots of, music and other things. And then, all the other things that we talk about around preparation for sleep, right? Like environmental cues. I mean, lights out, blackout shades, comfortable things, those kind of things. It's very much an OT world, right? Because we look at all those details, the person, right? The environment and the occupation of sleep, right? So making sure we're really addressing all that with the client and with their family. But sleep hygiene is huge in this space because as you said, if nothing else, but the psychosocial worry of dying. Somebody else had their hand up, I think, Emmanuel.
Yes, thanks, Anne. I wanted to ask regarding OT role in hospice care where the patient, for example, has been diagnosed with dementia
Mm-hmm.
and cannot recall.
Yeah.
In terms of trying to plan what they really want to do, we know when they are gone or how they would be remembered, and that is not already in place. What do we do in that situation?
It's
Or,
a
maybe, sorry to, maybe the family have an idea of how they want to celebrate the loved one, but they don't really want, well, we wouldn't know anyways, but I'm just trying to, I don't know if you understand my question. Yeah.
I think I do, Emmanuel. It's a great question, right? If you really can't engage the patient fully in that discussion, you can talk to the family. And when I say family, I mean whoever their people are, right? Whoever their neighbors, friends, people, and and asking, tell me about him. Tell me about what he liked to do. Tell me, my dad, I knew he liked baseball, right? So we were going down watching baseball. But whatever, tell me about that person, and really trying to understand, because remember, now we're really the family slash people of really almost become your client, right? Because now we're really serving that as a unit and holistically, as we should be doing for every client. But I would argue that at end of life, the holistic lens has to come out, because we're addressing a pretty significant issue, right? And we need to make sure everybody's on the same page. But it is funny too. I have had clients that that have dementia, that are in more assisted living or whatever, and families might be telling me one thing, but I might be getting a different vibe from the client, and it is sometimes challenging, right, to find either whether it's around food or who they want to see, or whatever we might be, whatever event we might be trying to plan. Looking through old albums is something I do a lot with clients, in especially with dementia in assisted living, and really trying to bring back some of those memories, and that can elicit a lot of what's important to them. The beach, they like the beach. Let's get some beach pictures up here. But great question. Any other ones,
Thank you very
Sarah?
much.
You're welcome.
Is there like a template where we can use as OT for that?
Well, AOTA has, I know, a sort of an end of life role of OT thing, but I'm also happy to share any of my slides or any of the things that I'd be happy to talk with you about. And I know our community of practice, we do a lot of sharing of like literally tools. Like there's this Go Wish tool. It's like a card game that we use with clients at end of life, and you have to sort things that are important to you versus not so important to you versus not important at all. It's called Go Wish. Take a look. So there's lots of tools like that we can sort of elicit those goals, right? And elicit the understanding of what's important, because that's really what matters here. What do you want to be doing? Where do you want to spend your energy? Or what's pain interfering with that we can address? All those kinds of questions. All right, should we get on to the case study? I don't know where we are in time, Sarah. You can yell at me if I.
Yes, go ahead and you can present
Okay.
the case study here, and then we'll be headed into breakout rooms.
Okay.
Thanks,
Okay.
Anne.
You're welcome. So this is Mrs. F, who is a 90-year-old woman in the home health setting, living in her own home. She has multiple comorbidities, as you might expect, that she made it to 90. So happens often that we have a lot of comorbidities: congestive heart failure, hypertension, mild cognitive impairment, lots of osteoarthritis, for which she's had bilateral total hips and a right total knee in the past. She's had now multiple hospitalizations in the past 2 years. Okay, so she's been in and out of the hospital for things like pneumonia and dehydration and UTIs. Okay, so that's getting to be much more of a burden. And each time she comes out of the hospital, it's like her functional status has taken a little bit of a hit, right? And so we're not quite as able as we were before. She definitely has vision and hearing deficits. Excuse me, she has glasses and hearing aids, but not always very compliant with wearing them or wanting to, which you may have seen before. Her social history: this woman was a trailblazer. She was a business owner at a time when, women were not owning businesses. She really was a powerful force, liked to really direct her own care. Her husband had been dead for a long time. She had 5 grown children, lots of grandchildren, and they were in and out the house all the time. So she was very fortunate to have a lot of support. 2-story home, which we just put in a chairlift for. She does have a wheelchair and a bedside commode, which is that BSC, sorry, and a home health aide all the time, 24/7, who has really become her best friend, to be honest, at this point. She enjoys time with her grandkids, telling and sometimes repeating. Remember that mild cognitive impairment, repeating her stories, but she really enjoys telling those stories. She enjoys going to the beach each summer. In terms of her physical assessment, she has limited range of motion, bilateral upper extremities, some arthritic changes in her hands. She's MOD assessed to get to the edge of the bed, MOD to max to transfer with the arm down. So she's not doing a full stand, it's more of a squat pivot transfer. She's Max Assist for lower body self-care and Min Assist for upper body self-care. I will say she's okay with that assistance, just to give you a little hint as to what you might want to focus on. She's okay getting help in those two realms. And she's supervised, or maybe with encouragement for self-feeding. So that's Mrs. F. And I guess our objective here is we are going to go into breakout rooms when Sarah tells you, but these are the things I want you to discuss, to really look at using the palliative care continuum lens, right? How might we elicit the goals and provide goal concurrent care for Mrs. F, right? And then how can we as occupational therapy practitioners support her and her family and her system? She's got a pretty rich system of support for her. And what role might we have? What interventions might we bring to bear? And how can we add value? Really, so those three are a little bit mushed together, but sort of distinct. So just discuss what will we do here, and how can we help? And I think that's now breakout room, Sarah.
Yeah, that's great. So we'll head into breakout rooms. You'll have your facilitators. Thank you, facilitators, on those questions, and we'll come on back with some group reporting. I'm going to go ahead and pause the recording right now, and then. Hi there, welcome back from your breakout rooms. And if you're listening into the recording, our team just got back from a 15-minute breakout room related to Anne's case study. So we'll spend the next 8 or so minutes debriefing this case, and we'll put our facilitators on the spot, encouraging them to share some key takeaways related to some of these things. Take it away, Anne.
Hello, welcome back. I hope everybody enjoyed discussing Mrs. F and what might OT's role be for her. I don't know if somebody wants to maybe share what their group discussed around specifically the palliative care continuum lens and how we might elicit goals and provide goal concurrent care to Mrs. F. Does anybody want to jump in there?
Yeah, I'll jump in. So our team discussed a number of different things. It was a very robust conversation. And first was just asking the question to her, what does a good day look like? What matters to her? And along those lines, as we know, she's very much loves time with her grandchildren. So ideas that were introduced were trying to increase those opportunities for time with her children and grandchildren, whether it's in person or through like video calls. We also talked about giving her an opportunity to journal about her life and her knowledge, maybe passing along her wisdom in business, her lived experience as a successful business person, either through journaling or again, having her record it, or videotaping, having her making like a little movie or video recording, using different assessments to look at her dressing skills, her safety at home, making sure that using sensory as an approach to make sure she has enough stimulation, like tactile stimulation, looking at what equipment might be needed to improve her safety and her transfers. I think I caught everything.
Awesome, Claudia. It sounds like you guys did the full gamut of discussing all things. When you were talking sensory, did you talk at all more about her glasses or her hearing aids or any of those?
That was one of the areas. It was everything all together.
Yeah.
Improving her ability to see, hear,
Yep.
her sense of touch, tactile discrimination. Yeah.
Awesome. Great, thank you for sharing. Can anybody from another group maybe talk a little bit about that next bullet, which is more, you mentioned grandchildren, but how about supporting the family and supporting her whole system of care for her? Does anybody talk more about that?
No, I'll talk. In our group, we talk. One of the roles that we could do for the family is, first of all, from giving out the awareness of the commodities that she has, probably the hearing, the vision, and the cognitive impairments, all the things that are going on with her, the family should understand before we go to the management, so that it could be easy for them to know how to support her and understand her. So that was one of the main things that we said we could do to the family. Yeah.
Awesome. Any interventions anybody
What-
talk about in particular? That next bullet?
Well, we
Uh,
talked about mindfulness and using the Moho model in researching her interests and start leisure activities on them. And also we suggested the snoozle and multisensory environment.
Great. I love the mindfulness idea. I will tell you, she was a little resistant, but really did come along to enjoy that, especially as her activity level got lower. So that's great. How about that last one? How can we add value to not just OT and Mrs. F and her family, but to the rest of the team? Specifically, maybe about rehospitalizing. Did anybody talk about that?
well, maybe is it possible to first talk about the part of the interventions?
Sure.
Whereby we talked about the environmental modifications and maybe doing some more activity analysis, providing some more proprioceptive cues, the visual cues, since she is having some visual issues, and then understanding the difference between supportive care and maybe the palliative, which one is needed more. Then maybe improving on the transfers since she's using a wheelchair, and yes.
Great. And I will tell you that Mrs. F didn't, sorry, did somebody going? Oops.
Additionally, I think my group we discussed, with all being said, we also discussed about engaging all the team members to understand, highlighting the values that she has and her preferences, so that it would help in planning the interventions and adequately adjusting as the disease progresses. And so there were questions about of the management of the only question there was about pain management for PT. Someone had written a question on the group, so I don't know. It's like occupational therapy managing pain. Someone asked if that's not meant for physiotherapists. So I remember you mentioned that earlier, but maybe on a larger group, you probably want to touch that. Thank you.
In interacting in sort of terms of collaborating with physical therapy around pain management, is that what you mean? I think because in this case, at this point, Mrs. F was on hospice and did not have physical therapy coming, just had occupational therapy coming. And I think I'd point out, I forget who said it before, I think it was you that said, getting her her preferences, what's important to her, right? So if she didn't really care about improving her upper body strength or improving her transfers, she had the 24/7 care. You sort of have to, give that up a little bit and see what's really important to her. And to her, it was some of those things that the first group talked about, like legacy building and telling her stories and those kinds of things, right? So, and it's a little bit different, I think, of a model than a restorative care, which we're used to in occupational therapy. And it's more helping her decline with as much dignity as we can help her decline with, because she's declining. Right. So really assessing what's important to her and helping her engage in those activities. But great discussion.
Is someone in our group to the idea of what's OT's value to the team. Someone brought up the point that as OTs, we well understand both the biomedical model and the psychosocial model, and we really are a bridge for both models. And to communicate that to team members, we have a holistic approach. So the value we bring to the team is tying all these pieces together through those two models to look at the overall holistic view of the client, of Mrs. F.
I love that, Claudia. Yes, that bridge building is sort of my motif, right? Like, let's get everybody on the same page for this patient, right? I love it. Yes.
Awesome. Well, thank you everybody for debriefing this case. I do want to actually offer up the last minute or two for any other questions that you have for Anne related to the case or related to anything about this topic or her career. Thanks for putting your info there, Anne. I'll also pop it in the chat. Any questions, group?
I appreciate you all listening and caring.
Awesome. All right. Fantastic. Well, we look forward to continuing our work together next month as well. Thank you so much for joining and committing your own time for your own professional development. Of course, thank you to our speaker and our facilitators for keeping this process smooth and seamless for all involved. So thank you, everybody. Have a lovely rest of your week.
Thanks all.